Good afternoon and welcome. We're glad you could join us today. My name is Carl Eisenhower. I'm the Communications Director for the Alliance for Health Policy. There's been a lot of attention focused this year on potential legislative changes that would affect Medicaid and other parts of our health system. But it's important to understand that existing law gives the Centers for Medicare and Medicaid Services the authority to grant states a large degree of flexibility in how they run their Medicaid programs. So today we're going to talk about Section 1115 Medicaid demonstration waivers. Each administration takes its own approach to assessing waiver requests, and the Trump administration has told states to expect more freedom to design programs that meet the spectrum of diverse needs of their Medicaid population. What that means and what we can expect as attention shifts away from Capitol Hill and to CMS and the state capitals is the topic of our conversation today. Today's webinar is a project of the Alliance for Health Policy and the National Institute for Healthcare Management Foundation in collaboration with the Association for Healthcare Journalists. We appreciate the support of our partners at the NICM Foundation and AHCJ. We're very fortunate to have a panel today who can help us all better understand Medicaid waivers. Our panel includes Matt Salo, who's the Executive Director at the National Association of Medicaid Directors, Cindy Mann, a partner at Manat Health, and formerly the Director of the Center for Medicaid and CHIP Services under the Obama administration. John McCarthy is a founding partner at Spire Healthcare Strategies and a former Medicaid Director in Ohio under the Kasich administration. He also was the Medicaid Director for the District of Columbia. And Jake Harper is a reporter at Side Effects Public Media and WFYI in Indianapolis. Before we get started, a little housekeeping. On the right-hand side of your screen, you'll see a floating toolbar with an orange arrow. The orange arrow allows you to open and close that toolbar. If you open it up, you'll be able to adjust your audio settings. You can also access downloadable versions of today's presentations and submit questions for the Q&A portion of our webinar. There are additional materials for this webinar that you can access on our website. Our website is allhealthpolicy.org. Finally, if you're new to this topic or other topics in health policy, we want to make sure you know about the Alliance's source book on the essentials of health policy. The source book was compiled with support from the NICM Foundation, for which we're very grateful. It provides background and current data on key issues, including Medicaid. Our first speaker is Matt Salo. As I said, he's the Executive Director of the National Association of Medicaid Directors, and he'll give you an overview of how Medicaid waivers work and why they are important to states. So Matt, give me one moment. We'll pull up your presentation.
All right, well, fantastic. Thanks a lot, Carl, and thanks to everyone who's joining us on this webinar today. I'm always thrilled when there is a robust audience of people who want to learn more about Medicaid and all the aspects of it. We are very proud of the program that my members operate, and I represent the Medicaid directors in each of the 56 U.S. states and territories. And anything that we can do to make the Medicaid program and knowing more about the Medicaid program more accessible to either journalists or policymakers or the general public, always thrilled to be a part of that. So before I dive in with what should be a kind of a background and framing of the issue of Medicaid waivers, I do want to at least just point out to say that we do still have a couple of weeks left in September, which means that the curtains, if you will, on possible congressional activity around some of these issues is not yet quite over. So, but with that, let me frame this a little bit and then tee it up for our other expert panelists. So, hopefully you all know Medicaid is a program that's been around for a little bit more than 50 years, and it is essentially the healthcare safety net in this country. It is very large. We cover more than 74 million Americans, and very, very complex. We do a variety of very, very different things, covering more than half the births in the country, all the way to the majority of long-term care services in this country. And the one thing that I always want to make sure to stress is that I represent all of the states and territories, and they are all very, very different. But the thread that binds them all is the desire, the passion, and the commitment to reorient the U.S. healthcare system to achieve better care and lower costs, and to make sure that Medicaid is there in a sustainable way for the populations we serve. Now, what's really important, though, is that the Medicaid statute, which is now more than 50 years old, while it has been evolving slightly over time, and certainly a lot with the Affordable Care Act, much of the underlying law really is no longer relevant to the way that healthcare has evolved and developed over the past number of years. And so therefore that really leads us into a situation where, in order to be nimble, in order to be forward-thinking and driving positive reform forward, many states really end up having to do something called a waiver of various provisions of that statute. So we can do the next slide. And basically what states use waivers to do is a variety of things, some of which are very small and very common sense, such as the ability to do managed care, or the ability to provide home or community-based alternatives to nursing home care. But waivers can be used to do a variety of things, again, some of which are very small, some of which are very large, some of which are complicated, others aren't, and some of which are politically controversial, others are not. In general, waivers should be budget neutral to the federal government and should further the goals of the Medicaid program. Now, both of those seem relatively straightforward and common sense, but as I'm sure we'll get into later, those are actually more complex and interesting than you might think, and we'll get into more of that later. And I would certainly note that every state uses waivers, and most states use many, many, many of them. So, next slide. Just a couple of examples here. I know we want to talk mostly about the Section 1115 research and demonstration waivers. There are a couple of different others. There's practically an alphabet soup of different types of waivers that states can get. We want to focus mostly on the big 1115s. And I would just kind of note at the bottom here that the larger the reform, the more complex the type of negotiation, the higher up the political food chain these discussions tend to go. And states that are pursuing big picture reform waivers generally have, bring the governor into negotiations with the Secretary of HHS, the Office of Management and Budget, and the White House. So these are discussions and conversations that happen at the highest possible level. A couple of notes just on waivers in recent years. In the Obama administration, we saw a number of very, very politically and geographically diverse states, like Texas, California, and New York, get big waivers called DSRIP, or Delivery System Reform Incentive Payment Waivers, basically attempts to infuse money into the system to facilitate rapid and sustainable change in delivery systems and the push towards value-based care. There have also been fairly high-profile efforts by states like Indiana and Arkansas to do alternative approaches to the Medicaid expansion that was a part of the Affordable Care Act. Indiana using kind of a health savings account type of approach, and Arkansas using something called the private option, which is sort of a combination of Medicaid and the private exchanges. And then I would also note that there were a number of waiver ideas and approaches suggested by states but rejected by the Obama administration, including those that talked about work requirements for Medicaid beneficiaries, lifetime limits of Medicaid coverage, and other types of things that kind of broadly go under the category of personal responsibility. So, so that kind of gets us to today and a little bit of, well, what's happening now? I would say that what I think we would look to see for a lot of the states out there, states that had proposed ideas under the previous administration and were denied, will be moving forward with similar or more expanded approaches or requests to the Trump administration. And as we have heard from CMS Administrator Seema Verma, there is very much a desire in the new administration to be the administration that says yes to a lot of different state innovations. And I know that that John and others are going to talk much more about this, so I don't want to go too much in depth there. So next slide. So I would just kind of put this out here in what I hope is a very non-controversial or non-political way that that our association, the collective group of Medicaid directors, we've also talked a lot about waiver reforms because one of the things that we want to see is innovations that have worked and have proven to have worked, and in many cases we've got waivers that have been in existence for decades, 10, 20, 30 years in some states. We need to find a way to make those permanent, make those part of the baseline of the Medicaid program, and so that can really allow us to focus our collective state and federal and stakeholder energy on really thinking through new innovations and things that will enable us to embrace the direction that healthcare is going. And kind of the final point there is really healthcare reform and innovation is a very, very fluid thing. And the types of things that states were innovating with 5, 10 years ago were unheard of 50 years ago. The things that will be innovated 5 or 10 years from now might well be unheard of today, and that we need a process that works and that can be nimble and allow Medicaid to stay relevant in our efforts to improve the healthcare system. Next slide. So that's it for me. Couple of points for us. If you want to find out more about what the Medicaid directors are doing or thinking on these various issues, there's our website, our Twitter handle, and our fall information on our fall conference, which I would encourage everyone to attend. So thank you for having me.
Matt, while I still got you, you raised the fall conference. Is that something that is open to the media?
The fall conference is absolutely open to the media, and we encourage the media to attend.
Great. Okay. Well, thank you. Our next speaker is Cindy Mann, who's a partner at Manat Health and was formerly director of the Center for Medicaid and CHIP Services under the Obama administration. And Cindy, you need to give me a moment to pull up your presentation. All right, Cindy, welcome.
Okay, great. Glad to be here. Hello, everybody. I, too, love a good crowd that likes to talk about Medicaid. So I'm going to pick up from where Matt took us and talk a little bit about what has gone on in recent years and what's pending now and likely some prospects for the future, and leave us with a little bit on implications and questions going forward. So if you can go to the next slide, or the first slide, please. Not to drown you in legal minutia, but I wanted to just briefly talk about what is the legal authority that the Secretary has to do waivers. But before I do that, I think we lost that slide. Thank you. Before I do that, I want to highlight a point that Matt made at, I think it was the bottom of his first slide, which is said, and it's a common refrain, which I totally agree with, which is if you've seen one Medicaid program, you've seen one Medicaid program. And that's sometimes because of waivers, but also because there really are a lot of opportunities under the 50-year-old law that has been amended over time to shape the program in different ways according to a state's interest, local conditions, healthcare landscape. So waivers, some states rely very heavily on waivers, some states rely much less on waivers, and still they are able to do a fair amount of their own design through the state plan process. But of course, there are limitations to that, and so waiver authority is an important additional tool for states to rely on to test some new ways of doing things. So a couple things on this definition of the legal authority, and this legal authority actually goes beyond the Medicaid program. It sits more broadly in the Social Security Act, and the two things I'd point to are in the second bullet. These waivers are to be experimental pilots, demonstration projects, so they are designed under the statute anyway to test a hypothesis and get an evaluation, right? So you can imagine it would be a little bit strange in a program as large as the Medicaid program to simply give the secretary, any secretary, carte blanche authority to simply say, well, Congress said this, and you can only spend your money doing it this way, but I'm going to just let you do it otherwise. So it is really supposed to test new ways of doing this, innovations, and I'm going to come back to that later. And then the really big operative standard is also in that second bullet, which is that the proposal that the state makes to be approved by a secretary, it has to be found to be likely to assist in the promoting the objectives of the program. That's really broad authority. It's not unlimited authority, but it's broad authority. And of course, every secretary that comes in, every administration that comes in will have somewhat different views about what it fits into that boundary of promoting the objectives of the program. So I'm going to, if we can go to the next slide. Here's a review, and Matt touched on this a bit, so I'm not going to spend a time. Here's what we got. You know, if you look at the history of waivers for the last 30 years, you'll see trends, and the trends are driven sometimes by the predilections of the administration, the federal administration, but often really by the desires of the states as to what are they looking for, what's on their minds, what are they trying to do. So over the last, well, let's say during the Obama administration, the four types of waivers that we saw predominantly are managed care waivers. You don't have to do managed care through a waiver, but some states prefer it for a variety of reasons. While most states are already doing managed care, some of them used waiver authority to bring in new populations, new services. And the big area on this was bringing in long-term care services, which typically states had not put under managed care, and increasingly are trying to do that and to test that and see how that works for a more integrated delivery system. Matt mentioned also that there were delivery system reform waivers. These were often very big investments the federal government made to help states move their delivery systems from the current state to the desired state, and we now have 12 states that have these type of waivers. We also had some waivers. Some of them were long-standing, some of them were new during the last administration, where states got some Medicaid dollars to do uncompensated care pools. And then we got, which tend to be the high-profile ones, and where we see most of the activity at the moment, but I don't know that that will be where it stays for the next 4 years, is on coverage-related waivers. And as Matt said, most of the coverage-related waiver activity over the last period of time was when states came in and said, I'm interested in expanding Medicaid, but I don't want to do it through the state plan authority. I want to put some new policies in place. And he pointed out Indiana is one of the states that did that. So this is where we're seeing most of the energy right now, but not necessarily limited to the expansion populations. States are taking some of the waiver authority that was granted previously and stretching it, or trying to stretch it, as Matt said, to areas where the Obama administration may not have gone along with the full request. And also we have some states that are applying these kinds of concepts to the traditional Medicaid population, not just to the expansion groups. So if you go to the next slide, it gives you a sense of where some of the flexibility as well as some of the guardrails were for these kinds of expansion-related coverage waivers. And again, every administration will be interested in granting flexibility, or at least say they are, and every administration will come up with their set of guardrails. So let me give you a couple of examples here. One is, let's look at premiums. Lots of interest in states to do premiums as they were thinking about expanding coverage. And that makes sense. States were not necessarily used to going up to 138% of the poverty line. As they did that, there was a greater interest in thinking about where do premiums fit into the Medicaid program, which has traditionally been, other than kids, people with much lower income levels. What the Obama administration approved said, yes, you can do premiums, but let's limit how much they are. So 2% of household income, which is parallel to what the exchange would charge at the 100% of poverty level. But also importantly, in terms of what might be the process for going forward or the policies going forward, is that the Obama administration said, let's test how these premiums work and let's not cut people off for non-payment if their income is below 100%. So they allowed premiums below 100% of poverty, but they did not allow a state to eliminate coverage for somebody who didn't pay. And states dealt with that guardrail in different ways. A couple of states said, fine, it'll be a debt to the state, and the state can collect that debt through tax intercepts and other mechanisms. But the coverage would continue, and other states like Indiana put people into a less robust benefit plan if they didn't make the premium contribution. So we're going to see a lot of states testing those guardrails, both on the amount of the premiums that are going to be charged, but probably principally on the issue of conditioning eligibility for coverage for poor people on the payment of those premiums. As Matt mentioned, let me jump down to the slide on work requirements. So the Obama administration did not grant waiver requests. There were a couple. Did not grant waiver requests for, no, if you go back to the last slide, please. If you would go back to the last slide, please. So the Obama administration didn't allow a state to say, you will lose your health care coverage if you don't participate in work or training or education requirements, but did allow states, in fact, states don't need a waiver to do this, to encourage connections and referrals to those kinds of services. And those are going to be big issues. And as going forward, and as Matt mentioned, also there was some controversy about an innovation that the Obama administration did approve, which is to allow states, and the first state that did this was Arkansas, to enroll Medicaid-eligible people into qualified health plans, into the marketplace plans, the plans doing business on the marketplace. They were paid, still got Medicaid protections on cost sharing and benefits, but the delivery was through the marketplace plans. And there was a lot of back and forth as to whether that was a good thing or a bad thing. And a couple of states followed Arkansas and imposed that approach in their expansion programs as well. So if you go to the next slide, this gives you a sense of what's pending. If you could go to the next slide, please, thanks. What's pending now before the administration. And what this shows you is where a lot of the energy is among states. Also, if you know, for Maine, Utah, and Wisconsin, the states at the far right part of the columns on this table, is these are states that are beginning to take some of these policies that have been approved and implemented for the expansion population and think about seeking authority to impose these new changes with respect to the non-expansion population, the so-called traditional Medicaid group. So I want to jump to the next slide and just talk a little bit about evaluation. I've got some findings here from interim evaluations from the Indiana waiver and the Iowa waiver, and they both contain some really interesting findings that can help both Indiana and Iowa and also inform waiver policy going forward. But there's a real tension here, and I just want to point it out, which is that these are new policies for the Medicaid program. In many cases, far-reaching policies. Indiana not only has a premium, but has actually a lockout. so that if you don't pay your premium, you lose coverage, and then you're locked out for 6 months if your income is above 100% of poverty. And we all want to see how are those premiums really being, how are people able to meet those premium requirements? Does it work? Does it not work? Before we have lots of different policies around the country that impose premiums either looking like Indiana's or steeper than Indiana's, or that pick up lockouts. But at the same time, governors are eager to look at a waiver that's been approved for another state that they're interested in and say, I want one of those too, and if you granted it for state X, why not me? And that's a reasonable desire from a governor's point of view, but it points out some of the tensions around waivers, which are supposed to be experimental and demonstration, that need to get evaluated. And at the same time, there's a lot of interest from different states to pick up some of the policies that have been granted to another state. So if you go to the next slide, I just want to quickly touch on the other kinds of waivers, not the non-coverage waivers, the so-called pools, either for delivery system or for uncompensated care. And I think we don't really know where the administration is yet going on these waivers. The Obama administration really did invest a fair amount of dollars into these delivery system waivers. There's none yet that the administration has acted on. Texas will be the first one that comes up. It's up for renewal at the end of this calendar year. What the administration did do a few months ago over the summer is approve a renewal of Florida's waiver that has an uncompensated care pool, and it substantially increased the amount of dollars that it was making available to Florida through the uncompensated care pool. The pool jumped from $608 million a year to about $1.5 billion a year. All the funds are not for the Medicaid program. They are for hospitals providing care for the uninsured, and the hospitals are paying the non-federal share. So I think it's likely to pique the interest of a number of other states, and it'll be interesting to see how the administration addresses that in other states. Is it prepared to provide that kind of funding across the country for other states that ask for it? So let me try and wrap up a little bit with posing some implications and questions for us all to consider as we both close out this, have questions and discussions in the webinar, but as we think about this issue going forward. What is the new flexibility that the administration is promising? What will it mean? Well, if you think about in the context of Medicaid expansions, which is still the law of the land, that states can do the expansions, and there's 19 states that haven't and 31 states that have. The question is, will the new flexibility encourage some states that haven't expanded to take up the Medicaid expansion, states that said, well, I would have done it if I could get work requirements or if I could do eligibility below 138% of poverty? Will some more states come in? Or will the new flexibility be about rolling back the coverage that is now in place, either rolling back by income level or rolling back by just constraining eligibility in different ways? I think it is not really debatable that many of and the states themselves have identified this in their applications, that many of the eligibility and the coverage policies in the pending waivers will make it more difficult for people to get and to keep Medicaid coverage. Whether it's the premiums or the work requirements, or Wisconsin is proposing drug testing, time limits, those policies are inherently constraining policies. So we will see coverage be constrained, at least in those states, in certain ways, and how much it is constrained and whether it furthers the objectives of the program and improves coverage overall, I think depends a lot on how they get implemented and what the guardrails are. The new flexibility also, though, and I think John is going to talk about this a bit, can encourage states to develop other kinds of waiver proposals. So the ones that are really pending now are kind of the ideas that states had during the Obama administration, some of which got approved and some of which didn't get approved. And they're they're trying to stretch the limits of what was approved before and apply it to new populations. But there may be very different kinds of initiatives that states might want to think about and take up the administration's offer of greater flexibility. So I don't think the sample of waiver proposals that we see now is necessarily going to be what we see over time. And if you want to go to the next and last slide, that would be great. So I think a big question before us is, how will these kinds of, particularly the coverage-related waivers, but how will they affect delivery system transformation? This is, and Matt alluded to this in his opening comments, this is really where states are focused. How do we make our delivery and our payment system better so that we're delivering better care, and through some of those care improvements, better coordination, integration of behavioral health and physical health, some really hard stuff that states are tackling. But they're tackling it both to improve care and to think about how those improvements can reduce costs. To the extent that some of these new eligibility-related requirements, premiums, work requirements, drug testing and lockouts and so forth, increased churn, people come in, come out of the program and disrupt some continuity of care, how will those changes affect state efforts to improve care and lower costs through care improvements? I don't think anybody's intending to undermine those efforts, but I think often the proposals for some of these eligibility and other matters come from one a frame of reference, and really making sure that we're thinking broadly about maybe some unintended consequences, I think will be important. I've already raised the issue of evaluations, but I think it's a big question going forward. Will evaluations inform policy? Will the sort of stampede to get the waiver like the 5 other states have been granted overcome that? I think we'd all like to see a situation similar to maybe similar to what Matt was referring to, where when we have good positive results from evaluations, let's replicate that and let's make it really easy for states to move in those directions, and at the same time pay attention to either negative or troubling findings where either the policy needs to be abandoned, but probably more likely tinkered with, so that it can, the policy is put on a positive frame going forward. Finally, I will note particularly for, well, I was going to say for the reporters, but for others on the call, is that some of the policies that are being considered, I think will probably get challenged in court, and to see whether or not those original the statutory restrictions that I identified in the original part, the early part of this presentation, are these experimental? Are they testing a hypothesis? And do they further the objectives of the program? I think there's a lot of discretion in the statute. I'm not saying that the courts are going to necessarily constrain that authority, but I do think that we're likely to see some litigation on some of these waivers. So with that, let me turn it back over.
Cindy, thank you. Our next speaker is John McCarthy. John is the founding partner at Spire Healthcare Strategies. He's also the former Medicaid director in the state of Ohio under the Kasich administration, and he was also the Medicaid director in the District of Columbia before that. So let me pull up your presentation, John. And thanks for joining us, John. The floor is yours.
Thanks for having me, and I wanted to say a couple of things before we jump into my presentation. And when you're thinking about waivers, as Medicaid director, I got 2 1115 waivers approved, one when I was in D.C. and one in Ohio. They were both early coverage waivers. And then I also got one rejected when I was in Ohio. City didn't call out Ohio, but mine was one of the ones that got turned in that CMS said straight up no to on that one. It wasn't even a negotiation. It just was like, no, we're not approving this waiver. So I've been on both sides of this issue. The other thing I want to make certain that everyone understands, especially for the reporters, that when we're talking about waivers, you often hear people talk about, like, this waiver does this one thing. That's usually not the case. It can be, but waivers are just a mechanism for a Medicaid program to do something innovative. And Cindy's chart was very good in that it showed you all the different things that might be happening under a waiver. So some states like Tennessee run one 1115 waiver, and under that they just put all their new ideas. But another state may say, I want to run 3 separate 1115 waivers. So it's very important to know exactly what you're talking about when you're talking to a state, and a waiver isn't necessarily just a program. So on the first slide, one of the things that I'm going to be talking about is what have states been asking for, and a little bit I'm going to get into a little more of like why they're asking for these things. So you saw in Cindy's chart, one of the things is elimination of retroactive eligibility. You might wonder, like, well, why would a state want to do this? What is behind this? And it's pretty simple. The states are looking for an incentive for people to stay enrolled. So the thought behind it is with the insurance mandate, hospitals and FQHCs doing presumptive eligibility, meaning when you walk in, they can enroll you presumptively if they think that you'd be covered by Medicaid, and those costs would be covered. And then ultimately, hopefully, you go through the whole enrollment process and you're enrolled back to that date. And also, eligibility often in many states starts at the beginning of the month. So from that, states are wondering, well, why would we have to go back 3 months? All that does is simply encourage people to not apply for Medicaid and not start getting the services they need. So that's the view from that side. The other side of it is from providers and others, they're worried about loss in reimbursement, obviously, if they may not get paid for some of those things. And then for the individuals, there might be issues along the way of why they didn't enroll or things that happened in that area. Next slide. Another one, and Cindy touched on these, is payment of monthly premiums. And so what does this do? It provides an incentive to be involved in the purchase of your health care insurance. Also, one of the other things is that it smooths out the cliff in going into an exchange plan. One of the issues we did deal with in Ohio was when you're on Medicaid, your out-of-pocket costs are very, very small. Then you go into the exchange as you move, if you're in an expansion population, as you go above an income of 138%, so that's the 133 plus the 5% disregard, then all of a sudden your out-of-pocket expenses go up quite a bit. So it's how do you smooth that out in that area? And the other thing is that can be variable based on income, just so you understand. When many states are talking about these things like it's a premium, often they're not just saying it's just one flat premium no matter how much money you make. It's stair-stepped in some way, shape, or form. Another area is health savings accounts. I know in Indiana, people hear about that one quite a bit. Again, what it does is it provides an incentive for the person to be involved in the purchase of their health care insurance, so that they're, not just their insurance, I should say, but also their health care. So in some way, shape, or form, they're able to see how much money is being spent on the services that they're receiving. One interesting thing that was in the Ohio waiver to think about with the health savings account was when a person left the Medicaid program because their income went higher, the Ohio program had proposed a bridge account so that that health savings account went with the person, that person then could use those dollars to pay for those additional costs of that private insurance, whether it be on the commercial side through their employer or through the exchange, either one. So that was kind of a different idea of how does that money go with a person. So remember, those accounts are funded up front. Usually you put in some amount like $2,000, you get your Medicaid match from that from the state. So in that scenario, that person's leaving Medicaid and not paying for Medicaid services, but are using those Medicaid dollars. One of the things I do want to point out is a similar idea, not the same, it's not a health savings account, but a similar idea worked in the area of developmental disabilities and aging waivers. And the project was called Cash and Counseling, but it's now referred to as participant-directed. And that was, you gave somebody a budget. So these are individuals that are intellectually or developmentally disabled. You give them a budget to work within to purchase their own services. They also are able to do other things like negotiate rates and the number of hours of services. And all of the evaluations of those programs have been very good. And basically what you saw was that people had control, the overall costs of their service or expenditures for their services went down. Next slide. Work requirements, this is another one that comes up. I put on here the name is a misnomer. It's talked about quite a bit. While it often says work requirements, if you look into what states are asking for, they're often looking at things like, yes, employment, but there's also training, volunteering, or working towards some type of certification, education, things like that. There's often exceptions for people with various medical conditions, and often it's only applied to disabled adults, and so your kids and disabled adults are excluded. I want to bring that up because I know in the Healthy Ohio Waiver, when that one came up, that was one of the issues that was often talked about incorrectly, because people were talking about, oh, there's going to be work requirements for disabled people, and that wasn't the case. It was for able-bodied adults, and again, there was these other ways to go down that path. Cindy talked about this one. You're going to see this enrollment and exchange plan instead of Medicaid. And one of the things that you can see is, do you pick a level at which you do that? So is it people above 100% of the poverty level, or maybe people above 55% of the poverty level? In that scenario, you could have it. You could ask for it to be applied to children as well as adults, saying, hey, the exchanges are good. It's commercial insurance. It's better than Medicaid, and so let's enroll people into the exchange rather than in the Medicaid program. One of the things that came up around this one, I know we talked about Ohio, was there might be cost implications because often the premiums in the exchanges or in commercial insurance are higher than Medicaid. And so the state really has to look at what is the financial cost in this area. Non-compliance penalties is something that states have been asking for. And what does that mean? It's pretty simple. If a person doesn't follow the rules,